So, ma'am, I think let's start with Charlotte Maxeke. I think everybody wants to know when the hospital is going to reopen.
For the whole hospital to be functional, it will be handed over to us by the 15th of December, 2023. And remember the initial, from DID, the initial completion date was 2027. But after we've brought in National Department of Health together with GBSA, they have put the project of Charlotte on the accelerated project plan, which was signed off by the minister and the DG, Dr. Patelis. They then brought that to December 2023, 15 December 2023. Currently, what is happening is that we have the oncology. I think you know that cancer unit is open, even though we are still experiencing backlog when it comes to prostate cancer in particular, because of the shortage of staff. And if you remember well, we used to, men normally don't come, like we go for the tests and the breast and everything. They don't come. So we're on a campaign drive, I think 6 years ago, where we're testing and then diagnosing a patient. So currently, that is where the backlog is like very bad. Then with regard to
I just want to check with you specifically with the cancer patients. We've also spoken to breast cancer patients. They've been on the waiting list, some of them since 2019, specifically for radiation treatment.
Yes, I acknowledge that, ma'am, that we had a little bit of a backdrop because of COVID. I think the 2 years that were in the pandemic really impacted on almost everything, your health, your economy, and everything. So what we are currently experiencing is shortage of staff. And we have also approached a private sector so that they can come and do sessions with us, especially at Charlotte, because now I'm talking about Charlotte. But you find that when they come, they choose what type of cancer do they want to do. And because we're doing sessions, we just give them what they want. And we acknowledge that there is a challenge. We're also looking into reviewing our organizational structure. But now we are competing with private sector, Adel. They come immediately when they completed training, and then they come to work with us. And then because we have an issue around their salaries, and it's a bargaining a council issue that we cannot deal with as a department. So most of the time we find that they come and they go. But we will pursue the private sector, bringing in private sector to make sure that at least we are pushing to try and address the backlog.
Is this specifically in the oncology department at Charlotte Maxeke?
Yes.
Okay.
Yes. And it's not only at Charlotte. The shortage of staff is across, because Steve Biko and George Mokari and Bara. With Bara is different because we're still having the challenge of a banker, but they bought the machine. But with the others, like Steve Biko, they say if they can have staff, they can operate with, they've got 4 machines currently, they are using 2. If they have staff, they can use additional 2. So to help us to address the backlog.
Is there an issue with CT scans as well? We've heard of a lot of these breast cancer patients who have to travel from one hospital to the other because CT scans are broken.
The CT scan that we are using, it is not broken. The one that is in medical and accident unit, it was vandalized. I don't know what happened, that thieves, or if one might say, managed to get there. But you know, you can't do anything about the CT scan machine. You can't, even if you can take some parts there, there's no way that you're going to use. So when we went to check and do the inspection, we discovered that they just pulled out some of the things, I don't know, those connections. And then they took the keyboard. For what? I don't know, because even if you can use it on your desktop, that will not operate. Then that is what is delaying us to open the accident and emergency unit, because we had to call in Siemens, and then they came, they did the assessment. Then they said to order the parts, it will take them 2 weeks. And then they have ordered the parts. I've just checked now. And the only thing that is left is a processor. And then they would then submit a report. They've already submitted a report to the radiation board. Remember, because it was not in use, we have to go through that process again of accreditation. So hopefully, they said they will do this in 8 days to get the board to come and do the test and make sure that they give us a certificate that we can operate. But as for everything else is in place. The mental health ward that we identified there to use to offload pressure from Helen Joseph, that is in place. The cleaning has been done. The health technology has been tested. The air quality has been tested. It's almost ready. So the only thing that is holding us, because even if we can want to open it and bring in patients, if you can get a trauma patient, then it means that you must send a patient to another hospital for a scan, and then it's going to inconvenience us. But hopefully that will be done within that 8 days.
Are you specifically talking about the reopening of the accident and emergency unit at Charlotte?
At Charlotte, yes. And then what we also did, I visited Helen Joseph, I think sometime last year, where I then discovered that the accident and emergency unit has small cubicles, and which is not conducive for even the doctors and nurses to work and the patients. So we then also prioritized a project to also upgrade the accident and emergency unit of Helen Joseph. So we have budget for that. The processes of tender, I think they are at different stages now, so that as soon as the Charlotte accident and emergency is operational, then we can then start looking into how do we get the Helen Joseph as well, at almost the same standard as Charlotte Maxeke Hospital.
I want to come back to the cancer treatment, but I just want to ask you specifically with Charlotte Maxeke, there's a lot of staff that are leaving. We've heard of, I think it's 667 vacant posts. So what is your office planning to specifically do about that? I mean, it is a mounting problem.
Yes, I acknowledge that we have lost staff at Charlotte Maxeke for different reasons. And I've also mentioned that we are looking into filling those vacancies, and also into making sure that we are revising our organizational structure so that we can have enough staff to can deal with the cancer patients. So that process is currently underway in terms of filling those vacancies where the staff left for different reasons. So we're working into making sure that we fill those vacancies.
So do I understand you correctly that the equipment for radiation treatment at Charlotte Maxeke, that's in place? Is that what you're saying? But it's a staff shortage problem.
We do. No, Charlotte Maxeke, we do have equipment. If you're talking about the cancer, the radiation oncology, we do have equipment. And that one of the scan of the accident and emergency, we do have. The only challenge that we are having is BARA. Bara has 2 linear machines that they bought, but they did not, I don't know how they did it because I was not even here, without getting the bankers. They were supposed to do a turnkey project where you build and then install the machines. So Bara, that is the challenge that we're in, but we're currently trying to get a service provider to do the bankers. But even if they can have that, we're still gonna have a challenge of staff. So hence we're saying we are working on the organizational structure and will be assisted by DPSA to come and fast track, because if you put the position in the structure, you must be able to do job evaluation and then do many other things and cost it and then have budget for it. So that is where we are.
So if I understand you correctly, the radiation backlog is mainly because of staff. The Cancer Alliance has called this backlog a humanitarian crisis. I want to get your response on that. We've heard from many cancer patients who, while they've been waiting for radiation treatment, actually had their cancer come back. They had to go through the whole process again of getting operations, going through chemotherapy. We've even heard of patients that have died while they were waiting. So what is your response to the Cancer Alliance calling this a humanitarian crisis?
I cannot dispute that, and that is as a result of many reasons, as I've indicated, that when Charlotte was still operating normal, we did have a challenge, but it was manageable. But then the fire happened at Charlotte. Then the pandemic happened, COVID happened. In the process of COVID, we also lost a number of staff. So I think I acknowledge that, yes, we do have a crisis, but we are also working into making sure that we address that.
I want to talk specifically about nursing staff. We know about the 8,000 posts, the temporary nursing posts, that a decision was still going to be made about whether you can keep them, because I know there was some restraints around budget allocation. So first, just tell us a bit more about decisions around those 8,000 nursing personnel.
I think me and you understand that this is not a baseline budget. It was a COVID earmarked budget for COVID-19 when we were in the pandemic. And this 8,500 is also staff members, different categories, were appointed in different waves of the pandemic. And in the first year, because I joined the department, I'm only a year there. The first year of the first wave, the contracts were extended for a year, which year was ending 31st of March this financial year. And now we, as government, you know that there are different budget processes that are happening before you can be approved for budget. We then presented to a budget committee with a motivation that we still need this staff of COVID-19. We know that they are fixed term contracts, they have a beginning and end, and therefore we put up a motivation. But because remember, during COVID, other departments had also to reprioritize and then support us with budget and so forth. So the challenge was the numbers of COVID are getting down. The COVID positive patients are getting down. There are those facilities where they have 0 patients for weeks and weeks and weeks. So then, because I don't make decisions on the allocation, the committee, the budget committee. Then we received a letter from the budget committee that says, because of the reduction of the COVID positive patients, we're reducing your budget from 2.2 billion. In fact, it was 2.8 billion 2.2 for salaries, and then I think close to 600 or so for operations. So when you got that 1.1 billion for salaries, now it means you are getting 50% of your initial allocation. Then it meant you have to lay off some of the staff. Now, that was a very difficult decision to make, considering that we have an organizational structure that was approved in 2006. We are still working with that organizational structure, despite the fact that the population numbers of Gauteng have increased. We are sitting at more than 15 plus million population. And we're also catering for our neighboring SADC countries, even international. So you can just imagine when you bring the 8,500, it's a relief to many clinic doctors and nurses to say, we're getting an extra hand. And then when you come tomorrow and say you are taking that help away from them, they would not be happy. And we also were not happy, because we know that it's going to have a huge impact on our day-to-day operations. So we had to come up with a decision and work around the pressures of different hospitals. You have your Bara, which is seeing close to 45,000 patients per month. And I was also made to understand that of that 45,000 plus patients, close to 2,500 or more deliveries of pregnant women are people from outside the country. And Bara is not only servicing the people of Gauteng or Soweto, it is also servicing the SADC regions and other provinces in the country. And then you have your Charlotte, despite the fact that there was fire, there is other units that are still operational. And they also having their own pressure, which is also felt by Helen Joseph Hospital. And then you have your George Mokari, which is also servicing Northwest and other provinces, and Steve Biko, the same, servicing Limpopo, Mpumalanga, and other countries as well. And then we then have to make a decision based on the presentation and the pressures of different hospitals, to say we're going to retain 100% staff of these 4 academic hospitals and 3 tertiary, because Tembisa is the second, if not the highest, in terms of deliveries in the country. So we had to make that decision. And because of the fire at Charlotte, the head count of Helen Joseph also increased. We then had to make that decision that we are going to give this 4 plus 3, 100% retention of their COVID posts. But as I was explaining to the minister, this is a temporary solution, because come next year, we don't know how the country would, where the country would be when it comes to COVID, and then we might get further reduction. Then we then said, let us then request DPSA to come and assist us to look into the organizational structure, because we had been, I'm told there's been attempts to review the structure by my predecessors. So we are going to be bringing in DPSA to assist us, so that whilst we are still working this COVID post, we also creating a post and budget for them, so that when we go to Treasury and say, this is now the organizational structure of Gauteng, we think that with the pressures that we have, if this structure can be approved and budget can be allocated, we will be able to assist our communities.
Are you worried about the impact if these 8,000 posts, temporary posts, won't, you're not able to keep them? Are you worried about the impacts that this will have on healthcare services?
Yes, yeah, maybe to indicate that when we did an audit of all these posts, remember people come and go. We then discovered that it's more than 6,000 people that we are currently having on the system. And then because we took that decision, we are now feeling pressure. And then we then said the 4 academic hospitals and the tertiary, the cluster heads must go and discuss with the district and the regional hospitals, because they also had, remember, with them, we're not keeping 100%. And some of the staff members were not happy. Those contract employees of COVID, they were not happy, and then they started making demonstrations and in different hospitals. But we then engaged with the unions and then said, because we're sitting with this challenge and we can't keep everyone. We then decided to keep 100% of the COVID posts for the 4+3, and then with regards to the others, they must indicate which categories are they going to retain. And then the academic hospitals then said they will have to make a plan not to, the districts and the regional hospitals not to keep COVID patients. Then they can be treated either at Barra, at Charlotte, because Charlotte during the peak, we had more than 400 beds. Even with the fire, we had more than 400 beds for COVID patients. So we are currently working on finalizing a strategy for the regional and districts and the primary healthcare where there was COVID. Remember, in the process, we also had to implement vaccination rollout. So with the vaccination rollout, we are currently integrating the vaccine in the different primary healthcare facilities and in different hospitals. We're also making some pop-up sites, especially in the businesses where people having more than 50 employees to also set up those pop-up sites. Something that is positive, despite the difficult circumstances or environment that the healthcare workers were working under, and the program, the vaccine rollout program, we've to date vaccinated more than 9.8 million people who are eligible for a vaccine. And then our target is more than 12 million of eligible people too. So as you can see, we're not far from that, and we're still pursuing and also making partnerships with the private sector. On Saturday, I was at Tshwane, where the PSL allowed us to put up a pop-up site. It was the second one. So despite the difficulties, as this is something positive that we can also pride ourselves with, to say, despite the difficult and circumstances that we find ourselves in, but at least we managed to do that. And remember, if we vaccinate more people, it means we're working towards our herd immunity, which will also give us some relief in terms of pressures that we're experiencing in the healthcare sector.
Ma'am, I just want to speak to you about the level of healthcare by our nurses in public hospitals. I don't know if there's mechanisms in place to monitor these type of complaints about nurses, but we have had so many anecdotal stories coming our way from patients who talk about nurses who are it's ranging from rude to just really being irresponsible in the way that they care for or don't care for patients. We've heard in one serious case at Steve Biko that the patient was busy having a heart attack and the nurse refused to help him. And in a lot of these cases, the patients are not able to identify the nurses because they don't wear name tags. So I specifically want to ask you about policy in the hospitals around nurses that must be able to be identified. And then also, what is your sense of, these complaints? Is it an issue of training? Are our nurses overworked? Are the wrong type of people being drawn to these jobs?
Okay, firstly, every employee of the hospital must always identify themselves. That's policy. And in many institutions where I normally go and visit, I normally see a lot of nurses and doctors with some kind of identity, because it is important for us, so that when you complain, you must be able to say, Adel van Niekerk did this to me. So it makes it easy for us to investigate, because we would have at least the name and the surname of the person. And I must say, I also sometimes receive some of the complaints, and then would then investigate and redress with the family or the patient. In most cases, I think I've dealt with so many cases. But at the same time as well, we do have those patients that appreciate. I can show you a number of messages that I get from patients. And immediately, especially when they complain to me and I intervene, they would always give feedback to say, no, we appreciate that you intervened. When it comes to the nurses' attitude, we do have your matrons that are responsible to make sure that if we receive these complaints, they normally sit with the person. You might find that there are quite a number of issues that result into a person displaying a negative attitude toward the patient. And we have also trying to come up with a program of a Serve with a Smile. We started it at Polosong and Tembisa, and now Johannesburg will be rolling it out in their clinics and hospitals. They also have at Tembisa, they also have what they call, maybe if you can go to Tembisa or Polosong, a wall of a Serve with a Smile, where a patients can write on the wall how they feel about our services. The other thing that we also have, it's called Impilo app. Impilo app. That app has all CEOs of different hospitals with their telephone numbers, so that if you have a complaint, you can just go into the app, and then you go into that, and then you log your complaint, and then quality assurance will then investigate and then respond to you. So you can log the complaint once you are still in the queue, and they can be able to investigate that. So it's also something that we are using to strengthen our interaction with our patients.
But currently, it just seems like that communication process has totally broken down. The amount of malpractice cases against the department, do you think this is an indication of that breakdown? Do you agree there's a breakdown?
I don't know to what extent when you say there's a breakdown, because we have CEOs of hospitals who are in constant communication with the staff. We have management of the hospital that also communicates with the staff constantly. And we also have the executive management meeting, where we also communicate. I know that there was a gap of communication where the staff was complaining that if there's someone acting or someone appointed, that has not been communicated to them. So we then also encourage our communications to say, can you please assist different communications unit in all institutions, because health is a big institution. We have more than 400 clinics and more than 32 hospitals, and you have your forensic, and EMS is really big. So each and every unit has a communication unit. So we are working on that, into trying to improve that communication. But now that you are raising it, I think I will raise it with the CEOs, so that we can check which of these hospitals where they are not communicating a lot, to make sure that our staff are kept abreast, and if there's any complaint, then they can raise them with the CEOs and see how best can we address that. And we have also, I think yesterday, appointed a permanent HOD. I think that will also assist into making sure that we improve our healthcare services. Somebody with very high integrity, and has worked in the country and outside the country. So I think she would bring quite experience from international and then in the country, so that we can work towards improving the image and the health care that we provide in our community.
Are you comfortable with the mechanisms in place for patients now to go and make a complaint?
I might admit that maybe we need to do more. We need to do more to improve. And now that you are raising it, I am going to make sure that I follow through on all these challenges that we have indicated, because I don't see a point for a patient to go to an attorney whilst we can redress and resolve the problem. It will also improve in terms of also making the CEOs to account, because you can't have a situation where people cannot be identifiable. Because if you identify, I get quite a number of complaints from patients because my cell phone number, I make it public so that anyone who wants to complain, Adel can complain. I had a situation where at Bara, a patient was complaining 4 o'clock in the morning. I called Dr. Mankopane. He was off. He had to go to the hospital and check what is happening. That matter was redressed there and there. So my phone is a public phone. Anyone with a complaint, even yourselves, if you want to repair something. Yesterday, around 10, I received a message from one of the public members to say there's a patient that is at Helen Joseph. That patient was involved in an accident, and then they felt that the patient needs to be, I just want to read you this message very quickly. Then it says that the patient was involved in an accident, and then they feel that the patient was supposed to have been taken for a scan because they think there might have been a head injury also. And it was around 10. Then I said, please send the contact details of the patient. Then I sent to the CEO, and immediately then I got a response that they have attended. Maybe if you don't mind, I can put the recording on so that you can hear what the CEO said. So my phone is a public phone.
Okay. MEC, I just want to ask you, so one question is specifically about the maternity wards. So we all know about the Rahima Musa case. We also spoke to a pregnant woman that was at Baragwanath recently. She says there was no running water in the maternity ward. Send us some pictures. Some of the women had to sleep on the floor. Is there a specific problem at the maternity wards of these hospitals, or is it just indicative of throughout the hospital?
With regard to Rahima Musa, there are issues of infrastructure and the influx of patients. Rahima Musa, I think, if you recall, I think this year they will be 79 years or odd years. So it's a very old hospital that was designed at that time to accommodate the population at that time. But now, because we are also getting quite a number of patients that are coming from other your SADC regions. Some of them, they come from Park Station straight to either Bara, Charlotte, or Rahima Musa. Because remember, Rahima Musa is a specialized mother and child hospital. So they know if you go there, you get the best care. Rahima Musa, I think, if you recall, I think this year they will be 79 years or odd years. So it's a very old hospital that was designed at that time to accommodate the population at that time. But now, because we are also getting quite a number of patients that are coming from other your SADC regions. Some of them, they come from Park Station straight to either Bara, Charlotte, or Rahima Musa. Because remember, Rahima Musa is a specialized mother and child hospital. So they know if you go there, you get the best care. And what happened that day, that night, if one might say, is that these women, I went there on Monday to go. I said to the CEO, don't discharge those patients because they were elective Caesar. Don't discharge those patients. I want to come and interview those patients myself and hear from them what is happening. I hear, yes, your quality assurance report, but I also want to hear their side. So what happened that day is that there were 17 patients that were waiting for admissions. And then in the process, there were also emergencies that were coming in. So they were, as they were admitting, some patients were going for deliveries and there were shortage of beds because remember, we don't have a policy that says, no, we're full, you can go home. And then what happened, according to the patients, they said to me, nobody forced them to sleep on the floor. They told the doctor, and what they appreciated was that the doctors and nurses came to them and explained to them that, can you please be patient? As you can see that in the process of us admitting, there are emergencies that are coming in. So the patients understood, but they said they got tired of sitting on the chairs. And then they started sleeping on the floor. Then the doctor came to tell them that it is wrong for you to sleep on the floor. It is not allowed. It's risky. Can you please sit on your chairs? Then they said no. They made a choice to sleep on the floor. Then as they were sleeping, they just had a man walking around and then talking to them and say, why are you sleeping on the floor? And they were not happy that their husbands are not allowed to get into the admission ward. But there's this stranger who just came and then took pictures, and they were not happy that the pictures were on social media. And then I went there with a chief director hospital services from the office of the minister. Both of us were interviewing them. We heard what they were saying. Then they said that they feel that their rights have been there was a breach of that. So and then you know what is surprising? Out of all the 17 patients that were there, and I think we have interviewed about 6, only one was a South African. And I don't want to sound xenophobic, but the challenge is that some of these women, when they come from their countries, they never attended antenatal clinic. They come as emergencies. They are putting pressure on the system. The infrastructure of the hospital, it can only accommodate a certain number. So with regard to Bara, that one I'll have to investigate again because I am not aware of that. And the other one that I know has also high maternity unit is patients is Tembisa. And we're also planning to put up 300 beds at Tembisa. But because this was supposed to have been done long time ago, but because of the dolomite, that hospital, I'm told, is built in a dolomitic land. So some pockets of the land are dolomitic. So we could not put a brick and mortar structure. So we had to come up with another alternative to put up those 300 beds. But because of all those tests that need to be done, it's delaying us a bit. But it can also relieve us because remember, it's one of the hospitals that are doing most deliveries in Gauteng, if not in the country. But the one of Bara, I will have to investigate. This one of Rahima Musa, I went there, I investigated, and we even went to an extent of checking if there's space. We looked, they showed us the old gym. They said it can put close to about 40 beds. And then they showed us another facility, but infrastructure said, no, that one is not possible because we are not engineers. We go there and say we can put beds here. But infrastructure comes and say, no, because of this, you can't. So we then said, we'll do further investigations and see how best can we assist into making sure that we relieve that pressure from Rahima Musa. But you'll see as soon as Charlotte becomes fully operational, now the pressure will then move now to Charlotte because Charlotte is also dealing with specialized cases of maternity.
Just in terms of Charlotte, can you tell me what is the plan with the psychiatric patients that are being referred to Helen Joseph? Because I know some of the doctors are talking about a growing crisis there.
Remember the fire. I don't know whether did you go to Charlotte, Adel. The fire started just below the psych wards. And those psych wards, I think they were, if I'm not mistaken, they were admitting close to 40 psychiatric patients. And because that is where the fire, I'm sorry, that is where the fire started and that is where the damage is. So now psych patients had to be shared between Helen Joseph and Annandale Hospital. And with the new accident and emergency unit, they have also created a psych unit or psych ward that will accommodate close to 20 patients, 20 beds. And that at least can relieve pressure from Helen Joseph. Now they're also looking into, because the 20 they said because males are mostly admitted with mental illness. So they will focus on the males and then they will also create space for female patients. So at least that will relieve pressure. I acknowledge that has put a lot of pressure, not only at Helen Joseph, but at Annandale as well, because that is the closest to Charlotte that they can transfer patients to.
Are those patients still being, do they still move through like a temporary shipping container that's like a temporary holding place for them? And on that note, also, are you worried about safety issues?
Yes, I'm worried about safety issues because the psych patients has assaulted doctors and nurses. We do have a report on that, and it is really very risky. And when I visited the hospital, there was I think the psych patient smashed the, I don't know whether is it the door, glass door or something at admissions there. So it's very risky, and most of the time we get complaints of the doctors that have been assaulted by psych patients. But mental health is it's not only an issue of Helen Joseph or is basically provincial, if not a national issue. Because remember, because of COVID, there's a lot of things that happen. People have lost their loved ones, people have lost jobs, and people are using drugs and so forth and so forth. So that has also increased the pressure that was already there. So hence we're trying alternatives. Like now at Begimlangeni, we have, I visited Begimlangeni, they have converted an area into a psych unit. I went there, it's 100% compliant, and you know, there's no incidents of assaults, patients assaulting each other, breaking basins and so forth. But the challenge that we're having now, the families do not want to come and collect their patients when they're discharged. And they need to collect their patients when they're discharged so that they can make way for the new ones that needs to be admitted. So that is the challenge. And even if they, according to the CEO, they've also made means to provide transport to transport the patient, that patients that are discharged. When they get home, the families are saying, why do you bring this person here? And they don't want to take their patients. But we have an outreach program where a team of psychologists, social workers are also following up patients at home. So this is a societal issue that we need to work together with our communities, because to make way for those that are very sick. And there was another one was coming from the Northwest. They said they'd been tracing the family, and that person is fully healed, but you can't release a psych patient to the street without handing that person to the family, because the family must still make sure that they supervise, they make sure that the patient is taking medication as prescribed, so that the mental health user does not relapse and end up back in the hospital. So that is the challenge that we're having. But we are also working with the civil society to make sure that we assist each other into making sure that we make mental health a priority in Gauteng.
So just the last question, do you think it's fair to say that there's a public health care crisis in Gauteng?
I don't think to say it's a crisis, because there's a difference between pressure and a crisis, because there are those areas of healthcare where there is an immense pressure, but there are those where we are doing very good and there are those hospitals that we are really performing very well. And I think we can say there are challenges. Challenges in the sense that we have a shortage of staff, and we can attract and retain, especially the staff to take care of our cancer patients. But we don't leave it at that. We are also engaging private sector to assist us. Even though it is expensive, I think you also understand that cancer treatment on its own is very expensive. So we are also making sure that we are re-looking into our organizational structure, into making sure that we have the required number of staff to be able. Remember again, Adel, the disease burden has also increased. And I was listening to a clip of where the former Minister of Health, Dr. Motsoaledi, was saying, I don't know which year was it, they visited, Bill Clinton wanted to visit South Africa because of PEPFAR, just to come and visit one of the facilities. Then he took him to one of the clinics in what is it, Tshwane. Then one of the nurses there said 60% of the people that are giving that are coming for antenatal are from other countries. Then he also went with the then Minister Pravin Gordhan, because he went to plead with Minister to say, Gauteng is underfunded. Can you please increase the budget? So if Gauteng can when a budget is allocated, they can consider the population that was servicing, the burden of diseases that were, because it was COVID, and now there are post-COVID conditions that are also making our patients to go for different things because of the long symptoms that do not want to wear off. And there are many other, your TB patients that also dropped out during COVID. So we have to double our efforts to make sure that we get them back into the system and make sure that they get their treatment. There's still HIV and AIDS. Whether we like it or not, HIV and AIDS is still there. And it's also by putting pressure on our staff, including many other. You know, if you look at BARA, since 1994, we only built one a hospital in Gauteng, which is Bekimlande, and it is already also overflowing with patients. If BARA was supposed to do what their mandate is, we wouldn't be having the pressure that we're having. But you find that because it's in the township, people just go there for headache. People just go for minor ailments that they could have used the clinics to do that. Some of them go for deliveries at BARA where they were supposed to have gone to MOU or CAC to do deliveries. So because there's no other alternative, they have to go to BARA. And I don't know, I think it was Monday or Sunday where I got a call from a young girl who said, I brought my mother to the clinic, to BARA. Then they say to me, why didn't you take your mother to the clinic? And he says, it's weekend and some of the clinics are not working. I don't have any alternative, but I have to come here. So as well, those are the challenges that we're facing. The other challenge, Adel, is the infrastructure. The situation that we saw at Helen Joseph, at Rahima Musa, it's also related to the infrastructure because they do have beds. Ne? They do have beds that were donated, and we also buy beds every time. But there is no space to put up those beds. So we're also thinking of, the CEO was saying, we're thinking of partnering with other stakeholders that can maybe assist us in putting up those, what do you call those containers? They are very decent, they have aircons, and some of the clinics do have those containers. I don't know, the park homes. So that we can create space. Most of our facilities, their aging infrastructure is so bad. Even at Rahima Musa, I was asking them, the hospital is nice and clean, and but you always have those sewer spillage blockages because that hospital was built more than 79 years ago. So it is also a challenge for us to say we are operating with the facilities that were built years and years back with no anticipation of the increased disease burden that we're currently having, no anticipation of the increased population that we're currently having. So if we can have a proper infrastructure or build more facilities, and then I think we can be able to do that. But the main thing is our organizational structure is, I think it was approved in 2006, and most of the challenges that we're facing are historic.